next talk, I invite Arul sir, Director of Uma Eye Clinic, to share his views on multifocal ERG.
Morning. Thank you, Atik, for asking me to talk about ERG. We're all used to seeing ERG pictures, particularly some squiggles come out. We send out the patient asking for ERG in specific conditions, and we don't look at the pattern. We're all not taught to study the pattern and understand what is going on. We look at the report that comes off from whoever has done it. So ERG is quite important. It can be used in regular practice. We're not limiting ourselves to only retinal practice or neuro-ophthalmology or a practice which is involved with genetic disorders, where ERG is used far more commonly. But even in a day-to-day practice, it's very, very useful. It's a composite electrical activity from photoreceptors, Miller cells, and retinal pigment epithelium. So it's a use of a pattern reversal stimuli that's been proven and accepted as a viable clinical tool. So you have got a full field ERG, you have multifocal ERG, you have focal ERG, and a pattern ERG. So pattern ERG are the ones that are most easy to do and the most easy to interpret. So there are several indications, right from looking at visual functions in infants for you to find out is the retina functioning properly, and combine it with the VEP to find out whether the pathway is functioning properly, whether the occipital lobe is functioning properly, to diagnosing progressive retinal disorders as well as even AMDs. Now we can look at even early diagnosis of glaucoma and diabetic retinopathy here. So normally you would find that when you have this kind of ERG to be done, it's kind of messy. You have to have a neutral electrode on the forehead, and you have to have a contact lens on the eye. That's quite messy and difficult. So the newer ones are the ones that you can use in our practice. That one that we are using, you have a contact electrode neutral on the forehead, and then you have it on the lid. The negative point here is that this contact has to be perfect. So you should have a gel that gives you perfect contact. 2, the skin should be dry. 3, the skin should not be too lax and loose. That also gives a problem. So in very old individuals or saggy skin, we have a pretty bit of an issue. But then it can be overcome by meticulous application of the electrodes. So you have this kind of a pattern ERG response. This is how it looks on a normal patient. So there are several protocols. The concentric stimulus protocol, contrast sensitivity protocol, both are available. This is the normal graph we look at. First thing you look at is the graph that tells you on top 2 green dots, right and left. That means the stimuli or the recording is of optimal strength. If that is yellow or red, that means the whole system is not been recorded properly. Either because the contact is not good, patient is not cooperative, or it's not been stuck properly, or the gel was not there. Then this tells you whether it's normal. One need not sit and learn all of these squiggles. And you look at also, and everything is in green, everything is fine. It goes into yellow or red, something is wrong with that particular patient. The vertical axis indicates amplitude in microvolts. Horizontal axis is the time. So if you look at the ERG waveform, you have an N35, N50, N95. That corresponds to the milliseconds. So first one is negative, second one is positive, third one is negative, the fourth one is again positive. So this is how it looks, a standard one. So let's now look at all of that. Interpretation, only, please remember on ERG, unless the retina is at least affected to 30 to 40%, ERG will not show it up. So it's going to be extremely early, but that's early enough for us. So that's what we think. When I'll come back to glaucoma and diabetic retinopathy, it can be very, very thought-provoking. So this is a healthy response, and another is an abnormal response. A negative ARG is caused by a negative large A wave, X-linked retinoschisis, congenital stationary night blindness, quinine toxicity, siderosis, melanoma associated retinopathy. Non-recordable will be seen in Leber's congenital amaurosis, retinal pigmentosa, total retinal detachment, retinal aplasia. ERG in glaucoma. This is very, very important. We all are looking at now going away from the field, going to OCT, looking at the RNFL and the GCC. Well, we all know there is a 6 months to 9 months gap between an RNFL defect, GCC defect, before it can show up on the field. Well, the same thing, it can catch this about 2 years earlier. So properly done in a glaucoma suspect, if you see this kind of pattern, that means this is early glaucoma affecting the retina. So this will show up as RNFL defect and GCC 1 year later and show up in the field 2 years later. So it's extremely useful if done properly and followed up properly. The critical part is executing the examination in a proper way. You have to train yourself to do it or train your people to do it properly. Same, this is a glaucoma suspect. One eye is absolutely normal, other eye shows an issue. Look at the waveform itself, shows you the difference, but then you can straight away get it very, very easily. This comes with glaucoma suspect with OHT. So where there's an increased intraocular pressure, again, both eyes show that there is early damage. Though RNFL is fantastic. Everything is fantastic here. So this shows up almost 2 years ahead of time. So it's a useful tool. In diabetic retinopathy, again, you can catch these things very, 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 very early. But whether at that early point, you are justified in starting treatment on the patient or applying a laser on this patient, or are you going to now earmark this patient for more close follow-up over a period of time? That is left to our interpretation, what we do. So probably what we will do at this point of time, not rush into treatment, but you would probably now see this patient every 3 months or 6 months instead of seeing him once in a year. So that gives you a very, very good diagnostic, early diagnosis for all of these conditions. So contrast sensitivity ERG, if you do that, that catches diabetic retinopathy much faster than the other methods. And in optic neuropathies also, it is very, very useful. Leber's optic neuritis, you see these kind of a thing in macular dystrophy. So all of these conditions, you can have the ERG giving you a diagnostic aid. So it's a clinical tool to diagnose retinal disorders, a valuable tool in diagnosing early glaucoma and DR. So this kind of easy to perform ERG is a valuable tool in a day-to-day practice, while actually if you're trying to do very advanced research work, you have to go for the higher end ERG. It's also probably about 8 times more expensive. So this is quite inexpensive, easy to use product. Thank you.
What is the time? How long does it take to do one ERG?
The maximum time is spent on getting the electrodes properly positioned. You get that, it takes about only 5 to 10 minutes. So getting the electrode properly done, especially in an older individual, in a sweaty individual, in a person with very lax and wrinkled skin, that is a catch. So your people have to be well trained in that, and the gel should be used properly. It's very tempting to, these electrodes are expensive. It's very tempting to reuse them, but in reuse them, unless the young patient, you can't reuse it. So older individuals, better to go spend the money and have a new one for each patient.